You are a healthcare professional who treats spider veins. A patient comes in for a consultation about their leg spider veins. You go through the assessment, you explain microsclerotherapy, you describe how many sessions they are likely to need and what results they can expect. And then they say, "I've been reading about laser treatment. Is that better than injections? Should I be having that instead of microsclerotherapy?" It's a question that's not just hypothetical. It comes up increasingly often, and it deserves a genuinely honest answer, not a dismissal and not an overclaim. Because the answer is not as simple as yes or no. The evidence is far more interesting than that. In this video, I'm going to walk you through what the published evidence and international guidelines actually say about microsclerotherapy and the principal alternatives: transdermal laser, intense pulsed light, radiofrequency thermocoagulation, and a specialist combination platform called CLaCS. I'll explain when microsclerotherapy is the right choice, when alternatives have a genuine role, and when a combination approach may give your patients the best possible outcome. I'll also tell you about the techniques I use in my own practice alongside standard injection treatment and why I think they matter for clinicians who want to offer a complete spider vein service. It's the combination we teach on our hands-on courses. Let's start with the patient's question. When a patient asks whether laser is better than injections, what they're usually responding to is a marketing claim they may have read somewhere, or a recommendation from a friend, or simply the assumption that newer and more technological means better. That assumption is understandable, but it's not always supported by the evidence. And here is the honest position. When you look at the primary clinical trial data and the major international guidelines, microsclerotherapy remains the best supported first-line treatment for leg telangiectasia and reticular veins, not because nothing else works, but because nothing else has matched it on the combination of guideline endorsement, trial evidence, clinical flexibility, and accessibility, and that includes affordability. The European guidelines for sclerotherapy in chronic venous disorders give sclerotherapy a grade 1A recommendation for both reticular veins and telangiectasia. The 2023 American Multi-Society Guidelines from the Society for Vascular Surgery, the American Venous Forum, and the American Vein and Lymphatic Society recommend sclerotherapy with liquid or foam as the standard approach for symptomatic C1 disease. The EASY study, a double-blind, randomized, placebo-controlled trial, demonstrated that active sclerosants, polydocanol and sodium tetradecyl sulfate, significantly outperform isotonic saline for telangiectasias and reticular veins. That's placebo-controlled evidence, which is still the exception rather than the rule in this field. Good quality evidence is notably lacking. That's why the EASY study is so important. So the starting point for answering your patient's question is: injections work, they're well studied, and they are recommended at the highest guideline evidence level. That is not an opinion. That's what the evidence base currently looks like. The question your patient is really asking deserves more than that, because there are specific clinical situations where alternatives have a genuine role, and there is now meaningful trial-level evidence for at least one combination approach that could improve outcomes beyond what standard injections alone achieve. Let me go through the options one by one. The most commonly used laser for leg telangiectasia is long-pulsed Nd YAG at 1064 nanometers. It works by selective thermolysis. Hemoglobin in the vessel absorbs the laser energy, which generates heat and destroys the vessel wall. No needle, no injection, no sclerosant solution. That sounds appealing, and for certain patients and certain vessel types, it is the right choice. The 2023 American Guidelines specify exactly when laser is recommended for C1 disease, sclerosing allergy, needle phobia, sclerotherapy failure, small vessels under 1 millimeter associated with telangiectatic matting. Notice in that left column what those indications have in common. They're all situations where injection is either impossible, unsafe, or has already been tried and has not worked. The guideline is not saying laser is better, it's saying laser is appropriate when injection is not the right tool for a specific patient or a specific clinical situation. Now look at the right column. A prospective randomized trial by Parlar and colleagues compared foam sclerotherapy with YAG laser for lower extremity telangiectasias. Both treatments were effective, but the laser was significantly more painful. A 2023 network meta-analysis did suggest a relative advantage for YAG laser in telangiectasia clearance, but the heterogeneity between the trials in that analysis means you should be cautious about interpreting it as definitive superiority across all clinical settings. The honest answer to give your patients is this. Laser works. It has a clear role in specific situations, but for most patients with standard telangiectasias, it is not superior to microsclerotherapy. It's more painful, and the capital cost of a dedicated YAG platform is considerably higher. That means the cost to your patient is higher. Now, if your clinic has a laser, it's a valuable addition for the cases where injection is not the right option. If you're buying a laser specifically to treat leg spider veins in preference to microsclerotherapy, the evidence does not support that decision, and you may be making a costly financial blunder. Intense pulsed light, or IPL, uses broad spectrum, filtered light rather than a single wavelength. Many aesthetic clinics already have IPL platforms for skin rejuvenation, facial vascular lesions, and pigmentation work, so the question of whether it can be used for leg telangiectasia naturally comes up frequently. The honest answer here is that the verified comparative evidence base for leg telangiectasia specifically is very limited. IPL does not carry a formal guideline recommendation for C1 leg vein treatment in any of the major guidelines reviewed in my companion blog article, the link to which is in the description below. Now, that doesn't mean IPL has no role. In a clinic that already has a platform, an IPL platform, it may be useful for superficial red veins in patients who are not suitable for injection or laser, but it should not be positioned to patients as equivalent to microsclerotherapy on current evidence, because that claim is not supported by the primary data. And this brings us to the section I want to spend most time on, because it's where the most clinically relevant new evidence sits, and because it has direct implications for what you can offer your patients. In 2021, Dicken and colleagues published a randomized pilot trial in phlebology. They took 111 patients with C1 spider veins and randomized them into two groups. The first group received standard liquid sclerotherapy alone. The second group received liquid sclerotherapy immediately followed by low-energy percutaneous radiofrequency thermocoagulation at 4 MHz. The results in the combination group were better. Patient-rated cosmetic outcomes were superior. Rates of hyperpigmentation were lower. The amount of trapped blood was reduced. The patients in the combination group needed fewer total treatment sessions to achieve their final result. That last point is important from a practical point of view. Fewer sessions means less of the patient's time, less of your time, and a more efficient clinical pathway. Now, before I explain why the mechanism makes sense, let's be clear about the limits of this evidence. This is a pilot study. It's not a large, multi-center, randomized control trial. The follow-up period was short, and the trial specifically enrolled patients with isolated C1 spider veins. It excluded patients with reflux and excluded larger feeder veins, so we can't automatically extrapolate those results to every patient who walks into your clinic. But what we can say is that this is the highest quality direct evidence currently available for this combination approach. It showed a benefit, and the proposed mechanism is coherent. It makes sense on a mechanistic level. So why does adding radiofrequency thermocoagulation after injections by microsclerotherapy appear to improve outcomes? The proposed mechanism is this. When you inject sclerosant into a telangiectasia, you damage the endothelium and trigger a process of vessel obliteration. But in the period immediately after injection, before the vessel has fully closed, there is residual intraluminal blood sitting in contact with the injured endothelium. It forms a coagulum. That blood, specifically the red cells, breaks down over the following days and weeks, releasing hemosiderin into the perivascular tissue. Hemosiderin is the iron-containing pigment that causes the brown staining that patients find so annoying and distressing after sclerotherapy. The hypothesis is that low-energy radiofrequency thermocoagulation applied immediately after injection induces vasospasm in the treated segment. That spasm reduces the volume of residual intraluminal blood at the moment when the sclerosant is doing its work. Less trapped blood means less hemosiderin deposition. Less hemosiderin deposition means less pigmentation. Now, we don't have histological confirmation of this mechanism, but the clinical outcome data from the Dickon trial is consistent with it, and it aligns with what many experienced practitioners observe in clinical practice. Adding RF thermocoagulation is a good option. It doesn't require replacing your injection technique, it builds on it. One further point worth making is that radiofrequency thermocoagulation at 4 MHz is not only applicable to leg telangiectasia, the same technique is used for facial spider veins, which is an important and growing part of many aesthetic clinic services. Learning how to use radiofrequency ablation, also known as shortwave diathermy, for one indication gives you a tool that is applicable across multiple parts of your practice. We teach radiofrequency thermocoagulation at 4 MHz on our Vein Care Academy hands-on courses, both as a standalone technique for facial spider veins and in combination with microsclerotherapy for leg telangiectasias. I mention this because I think it's one of the most practical additions a clinician can make to a C1 service, and the Dickon evidence gives us a basis for that recommendation beyond my own personal preference. Fourth option I want to cover is CLaCS, Cryolaser and Cryosclerotherapy. CLaCS is a combination platform that delivers external YAG laser photothermolysis and simultaneous skin cooling combined with immediate sclerosant injection. The idea is to treat both the surface telangiectasia and the feeding reticular network in a single coordinated session, while the cooling reduces pain and limits epidermal injury from the laser energy. A 2024 randomized controlled trial by NASA and colleagues compared CLaCS directly with conventional sclerotherapy and found CLaCS superior for telangiectasia and reticular veins. A 2023 triple-blind randomized trial by Cordillero and colleagues assessed the CLaCS method using two different sclerosant protocols and found both safe and effective. So this is promising evidence, but here's the thing, and this is important. CLaCS is not currently available in most UK aesthetic or phlebology clinics. It requires a dedicated Nd YAG laser, a cooling system, and dual modality operator expertise. It's a specialist center platform, not an add-on to most C1 services. There is no direct head-to-head trial comparing CLaCS with RF-assisted microsclerotherapy. So we can't say with certainty which combination approach is superior. The comparison between them is currently indirect. My position is this: be aware of CLaCS, understand what the trials show, and know when to refer to a specialist center. I'll be covering CLaCS in much more depth in a dedicated future video and article. So be sure to subscribe to my YouTube channel and check out the link to my email newsletter so you don't miss out. For now, the practical message is that for most clinicians, building or expanding a leg spider vein service or a facial vein service, RF-assisted microsclerotherapy is the more accessible and immediately applicable combination pathway. It's the most affordable and it's the easiest to learn. We include it in our one-day hands-on training. So let's go back to where we started. Your patient asks, is laser better than injections for my leg spider veins, my leg thread veins? Here's how I would answer this, and here is how I think the evidence supports what I would say. For most patients with standard leg telangiectasia and reticular veins, microsclerotherapy is the right starting point. It has the strongest evidence base, the greatest clinical flexibility, including the ability to treat feeder veins in the same session. And there's no significant capital barrier. No other single modality currently displaces it. Without doubt, it's the single best modality. For specific patients, laser has a clear role. Needle phobia, sclerosing allergy, very fine vessels under 1 millimeter, telangiectatic matting following previous treatment. In those situations, laser is not second best. It's the right tool. For clinicians who want to get the very best results in highly selected cases, particularly where reducing pigmentation and improving cosmetic satisfaction matters most, adding RF thermocoagulation, also known as shortwave diathermy, adding that to liquid sclerotherapy is now supported by randomized pilot evidence. The Dickon trial gives us the basis for that recommendation, and the mechanism is biologically coherent. For complex presentations, mixed telangiectatic reticular networks, treatment resistance, or recurrent disease, and I'm talking here about recurrent disease where you've excluded feeder veins, a localized feeder perforator, or axial reflux in a saphenous vein or a tributary, CLaCS may offer a solution. And there is sufficient evidence to recommend it in these situations, but it requires very specialist infrastructure and referral where that infrastructure is not available locally. So in answer to your patient's question, the honest answer is clearly injections remain the gold standard for most cases. But the options have broadened, and there are now evidence-based ways to improve what microsclerotherapy alone can achieve. That's a more complete and useful answer than simply defending the status quo. So let me bring this all together and sum up the main points from this discussion. Microsclerotherapy remains the best supported first-line treatment for leg telangiectasia and reticular veins. There's grade 1A guideline endorsement, placebo-controlled trial evidence, the benchmark against which alternatives must be judged. Transdermal Nd YAG laser has a defined role for needle phobia, sclerosing allergy, very fine vessels, and telangiectatic matting. It shouldn't be used for everyone. It's a selective tool, not a first-line treatment. IPL may have a role where this platform is already in the clinic, but it doesn't currently carry any guideline endorsement for leg C1 disease. RF thermocoagulation added to liquid sclerotherapy improves cosmetic outcomes, reduces pigmentation, and reduces treatment sessions. These results are from a randomized pilot trial. The mechanism is biologically coherent and for isolated C1 spider veins, this is the most accessible combination pathway currently supported by primary evidence. CLaCS has the strongest direct evidence that it may be superior to conventional sclerotherapy, but it is a specialist combination not currently available in most UK clinics. For a full breakdown of the evidence, the guideline positions and the tiered framework, the companion article is linked in the description below. It includes the evidence tables and the complete reference list. If you found this video helpful, please give it a like and consider subscribing so you don't miss out on my next video. Please check out all the links and consider subscribing to my email newsletter. My name's Dr. Haroun Gajraj. Thank you for watching.